Morning. Welcome to the workshop on the clinical decision support systems. My name is Munir Pirmohamed. Those of you who do not know me, I am an academic just down the road in the University of Liverpool, so I didn't have to walk very far to get here, which is always nice. But welcome to Liverpool, and welcome to this building, which is a fantastic building, which was built during the pandemic. And the views are great. And if you like Liverpool Football Club, the stadium's over there. So I set up the UK Pharmacogenetic Stratified Medicine Network about 10 years ago. Since then, it's been growing in numbers. We have over 1,200 members. And Christine McNamee, who you've been speaking with and liaising with, runs the network on a day-to-day basis. So we need to thank Christine for organizing this workshop and so on, which is great. So really great to see so many people here. We have got people from not only the UK, but also from many countries, Italy, Turkey, and also from Australia as well. There is at least one or two people joining online from Australia. So hopefully you can hear me online as well. And welcome to this, which I think is a really exciting thing to be able to discuss. And the plan for the day is that we will have some introductory talks in the morning and then some industry-related talks in the afternoon, and then we'll have some time for discussion. Early this year, we published this report, which is the Royal College of Physicians, which is where this building is, the Royal College of Physicians, and the British Pharmacological Society. And this is very much about personalized prescribing, how you can use pharmacogenomics to improve patient outcomes. And we presented the evidence that's in the literature, saying it was now the right time to implement pharmacogenomics within the UK NHS. Although it's focused on the UK NHS, it actually is applicable to any healthcare system in the world because there are many common elements in there. So one of the areas we highlighted was the need for clinical decision support systems. Unfortunately, there's a knowledge and skills gap in our workforce in terms of pharmacogenomics and in terms of drug-drug interactions as well. And so we need decision support to be able to help the clinician at the front end to be able to prescribe the right drug at the right dose for the right patient. And that is critical, and that's what this report is about. So if you haven't read it or haven't seen it, then it is available. If you just do personalized prescribing on Google, it will come up as a first link, and you can download it. But for clinical decision support systems, I'm going to tell you what I would like to see. That we're going to hear many different things. And this is a challenge. This is my challenge to you. And we may change those at the end. And I'm really looking forward to hearing from all the colleagues and so on. But this is a challenge that we need. And these are the key things that we need. So the first thing is we need clinical decision support systems to be intelligent. What I mean by that is that we do not want the whole of a drug interaction formulary dumped into the clinical decision support system, and the doctor, nurse, pharmacist get hundreds of pop-ups. Because what they're going to do is they're going to switch them off. Right? So we want something intelligent which takes into account the individual characteristics of the patient, the renal function, the liver function, etc. And that's really important. It's got to be intelligent. Second, it's got to be interoperable. Although in primary care, we have two main systems in the UK. In other countries, obviously, there are many different systems. And in hospitals in the UK, there are many different systems. So we want some interoperability between different systems of that. And that is going to be really important. The third aspect is integrated. You can see I've got 3 eyes and there's a fourth eye. So it's integrated. It's got to be integrated into the decisions we make. So it's got to come up with instructions on what to do. If it's standing outside the usual system, the electronic health record system, it's not going to work. Nobody's going to use it. So it's got to be integrated into your electronic health record systems for it to work. And finally, it's got to be inclusive. What I mean by that is that we've got to take into account the fact that our demography is changing. The numbers of people who are above 75 on multiple drugs is increasing. We are bringing in new technologies, genomics, etc. So it's going to be inclusive in that way as we move forward. We can't just have drug-drug interactions, but we've got to have drug-drug interactions in a much more inclusive and much more intelligent manner, whereby we just focus not on the two-way interactions, but the three-way interactions, four-way interactions, and what effect it has. Now, nobody may have something like this at the moment, but this is what we need to work towards. And I think, as Voltaire said, we can't have the perfect be the enemy of the good. So we need to start somewhere, and we need to move towards the perfect solution, which may take us decades, but that's the challenge. And you may sort of disagree with me, and you'll have plenty of time later on to say I'm talking rubbish, which is fine. I don't mind you telling me that. But this is where we need to end up with, if that's okay. So thank you very much for attending. So I'm going to stop talking now, and I'm going to chair for the rest of the day. So I'm going to introduce Professor Reecha Sofat, who's a colleague of mine at the university here at the Department of Pharmacology. And Reecha is the Breckenridge Chair of Clinical Pharmacology and has been looking at this and actually what do you need for decision support systems. So Reecha.
I'm much shorter. Great, thank you very much for asking me to speak. And I think I'm just going to continue actually in setting some challenges as Munir started, and hopefully through the day that we can begin to answer these. So I'm going to talk about some work that we did with the PRSB to try and think about what challenges there may be of incorporating pharmacogenomics into decision support systems. So just to make sure that you're in the right place, just a little bit of revision. So as we all know, the most common variation is single nucleotide polymorphisms. The central dogma is DNA makes RNA makes protein. Some of these proteins are involved in drug metabolism, and this is DPYD as an example, where if you have SNPs in the DPYD enzyme and you get 5-fluorouracil, you can't break it down properly, and then you get toxicity. And this is exactly what we want to try and address and reduce harms to patients where they are absolutely avoidable. And DPYD, of course, isn't the only example. There are many drugs which have genetic variation that underlie their metabolism. And the idea is, of course, that all of us, well, some of us in this room take drugs regularly. All of us will take drugs, or at least one drug, over our life course. So it is likely that we will probably have a drug where we might come to harm, which is avoidable. So how do we build that into our systems in order to avoid that harm? We've already built in quite a lot of things into our systems. So I'm a clinician. When I do a ward round, I have access to blood test results. I have access to radiology. They actually support me making my clinical decisions. But how are we going to incorporate pharmacogenomics, but in a way that is actually utilizable and useful to the clinician as well as the patient? So this is the landscape of pharmacogenomics alerting. So essentially what we have is we have a pool of raw pharmacogenomic data. This is either generated through research studies or through actual clinical studies in centres which can offer pharmacogenomic testing as well as implementation. And then there's this to and fro between genomic analysis as well as clinical outcome generation to see actually what the utility of the raw pharmacogenomic data is. And then there's this problem of alerts and notifications and how you do this properly. And the UK really have begun to lead the way here. So we've just heard about the pharmacogenomics report, but prior to this, the 100,000 Genomes Project has really brought focus of genomics into healthcare. But what we need to do now is to think about how we begin to action this genomics within healthcare. How does this genetic data live within the electronic health record? How can we use it through the life course of an individual, but also the life cycle of a medicine and a patient that uses that medicine? So this is what we're addressing today. A physician who uses largely electronic health records. Where is the genetic information stored? How can that be used at the level of prescription or dispensing, and then can be used for patient benefit? So what I'm going to talk about is some work that we did with the PRSB to look at pharmacogenomic alerts and to try and develop some guidance for use by healthcare professionals. And this was a collaborative piece of work. James Critchlow, who contributed to this work, is in the audience today as well. So for those of you who don't know what the PRSB does, so this is the Professional Record Standards Body, and what they're interested in is developing consensus-based standards for digital care records so that the information about patients can be shared whenever and wherever care is needed. So for example, I'm in Liverpool today. If I get admitted into a hospital in London tomorrow and I have a genetic mutation that actually means I shouldn't be taking a drug or I'll come to harm from that drug, how can we begin to think about how that data is incorporated into an electronic health record that is shareable between organisations? So the background to the project was that we were commissioned by by NHS England Genomics Unit, and this was after the 100,000 genomes had been sequenced and analysis was taking place. And the idea was to begin to understand how notifications should be used to signal pharmacogenomic information to prescribers and other stakeholders that are involved in dispensing or using medicines in the healthcare system. And because we understand that genomics information will increase dramatically, and there's a high volume of genomic records which actually have pharmacogenomic actionable findings, we need to begin to understand how to actually use this data in clinical care. And as I said before, the PRSB is all about sharing this information to provide safe and high quality of care. So what we did was a field synopsis. We didn't do a full systematic review because we were limited by time and budget, but what we wanted to do was to get the key individuals and talk to key individuals who had either piloted pharmacogenomics across the world and see what their experience was, but also talk to clinicians of their views of how pharmacogenomics could be implemented in the NHS and in other settings, and as well as patients to see what their views of pharmacogenomic testing was. We looked at the current state of implementation in the UK and elsewhere, and then actually focused on implementation challenges and had a set of recommendations. So I'll just go through the findings in the next few slides. And what we found from talking to people across the world, so this was across Europe, USA, and other places, is that actually pharmacogenomics currently, and I think this is still true, is pretty opportunistic. It's not standardized in any way, and it's not always evidence-based. It's based on what's often commercially available, so if commercial panels for pharmacogenomics are available, then that's what will be used. But actually, maybe we need to switch our thinking to say which gene-drug associations are evidence-based, which will be cost-effective to implement in a system like the NHS. And maybe we need to reframe that a little bit. Where pharmacogenomics was adopted, so again, this was opportunistic. At the time we did this work, there were no national UK-based strategies. Rather, they were centre-based or pilots. But of course, since then, we've got the genomic labs and we've got the genomic alliances and we've got specific pilots. The DPYD commissioning protocol was published as we were doing this work. So there has been progress since then, and I think with the genomic labs and the genomic hubs, we will certainly see advancement in how we can build a UK-based strategy. There's also the test directory, which Munir and others have led, which describes evidence-based drug-gene associations, so that actually you can, as I said in the last slide, you can turn this around from an opportunistic venture to actually an evidence-based venture. The highest adoption in the centres that we spoke to were where recommendations were really simple and prescriptive. So just tell me what to do and I'll do it, and make it really simple. And for those of you who are clinicians in the clinical environment or pharmacists in the dispensing environment, you need to have really clear instructions to be able to know what to do in a really busy environment where you might otherwise get distracted. So really unambiguous information. And where we did find that pharmacogenomics was being used, when they were used in electronic health record systems, they were pop-ups. And I'll come to the point that Munir made earlier on about what problems pop-ups can cause. there was often just static text to describe what the reason for the alert was. Sometimes there was the importance of the alert, so is this something that you need to action or something that might not cause as much harm as you might otherwise think. There was a summary of the relevant drug gene alert, but also a recommended course of action, so change dose, stop the drug, and so forth. The people and the surveys that we did were mainly electronic, but there are also paper-based systems, and the UPGx consortium, which some of you may know about, also has card-based pharmacogenomic alerts with a QR code, which will link to a website to give you some customized prescribing information. And then there was this classification of alerts that came through, which I'll talk about in a couple of minutes. So in terms of what information is being alerted and how the information was presented, so this slide just shows some of the examples that we came across. So some of the alerts were contraindication alerts. So here there's an example of allopurinol, and if you carry this mutation and if you're homozygous, this drug is contraindicated, and there's strong evidence to support this. So actually that gives the clinician or the prescriber or the dispensing pharmacist enough information to say, actually, I should probably question this prescription or not go ahead with this prescription at all. And similarly, there might be some dose adjustment alerts, like this example of simvastatin. And then I mentioned classification. So this classification kind of came out quite strongly. So when a physician or a prescribing pharmacist or healthcare individual prescribes or makes an entry in an electronic health record system, the pharmacogenomic information may be known or may be unknown. So if the pharmacogenomic data is not known, this is what we call a pre-test alert. So the system could therefore alert you to say there is an underlying pharmacogenomic association with this drug use and you should do a test. So, and the alternative would be actually the genetics is known, it is within the health record system, and you can then have a post-test alert, so you've done the test already, and then you can use the genomic information to actually make a prescribing decision. The active and passive is quite important, because the active is where the electronic health record system interrupts you and tells you to do something, whereas the passive alert is something that might not need to be actioned. And if it's not actioned, of course, it can lead to harm. So this is what an interruptive alert could look like. So as you're prescribing a drug, a pop-up comes up and says there is a pharmacogenomic alert. It gives you a recommended action. It directs you to some dosing guidelines so that you can see what that recommendation is. And it gives you an option of what to do, either cancel the order, override the alert, which, trust me, happens quite a lot clinically, or modify the order. But these are really important things so that we can begin to change our behavior within the system. And then the other thing that came up quite strongly was where to alert in the life cycle of a prescription. And I don't mean to make this slide complicated, but this is the life cycle of a prescription in a secondary care setting. So as a clinician, I might make a diagnosis and I action the treatment through a prescription that's written, and the prescription then might go to a nurse who will give the drug, but the drug might not be available on the ward, in which case it might go to a pharmacy, then the drug comes back, it gets administered, and so forth and so forth. And all the red arrows that are coming out of the boxes are all the possible mistakes, and they're probably an underestimate of all the possible mistakes that could happen in the life cycle of a prescription. So we have to be really, really clear and careful as to where we want these pharmacogenomic alerts to happen at the point of prescribing, but actually also look at the pathway that involves other staff in the healthcare system and where they could also action these alerts. So certainly nursing staff, we talk to physiotherapists, pharmacists, obviously, but there's a whole load of individuals who have prescribing rights that we need to be really careful to include. And this is just the equivalent in primary care. And again, we need to be careful about how we begin to involve community pharmacists. So it's the whole spectrum of not only primary care physicians, but also allied healthcare workers within primary care. And sometimes we forget that actually some of these people are out in the community, and actually they are the face-to-face contact with our patients. So how do we need to upskill them in order to develop these tools? But actually, how do we also integrate them into their their dispensing systems? I told you there were more questions than answers in this one. And then, of course, how this process will evolve. So there's the system and interoperability. So with everything digital, things need to be interoperable from one system to the other, and they need to be underpinned by standards. So the FHIR standards are something that are evolving and allow interoperability between systems. The genomics FHIR standards are there, but they need further development. And as pharmacogenomics comes of age and is deployed within electronic health records, we need to make sure that the systems are capable of being able to transfer this information. It was already alluded to that there are multiple system suppliers. So actually, how do we get these results from a primary care system to a secondary care system and back and forth so that actually the right decisions are made for patients at the right place? And of course, there's genomic information. So we might have sequenced an individual and we might not need to do that again, but drug gene pairs and associations will evolve and will be discovered. So actually we need to be iterative in our approach in how this information is upgraded. So in terms of the challenges to implementation, so what genetic information should we use? So there is really a mixed economy out there in terms of what is available. So 100,000 Genomes has sequence data available, there is exome data available, and I've talked already about gene panels which have been implemented as pilots. So we need to understand actually what genetic information are we going to use for pharmacogenomics. Again, how are we going to store this information? So how are we going to have the equivalent of the spine, not the spine that we're standing in, but the electronic record spine? So there's the NHS spine, which is a central record that can be accessed through primary and secondary care. Should we have the equivalent of the spine? So actually that genetic information is available wherever you are and whichever service that you're using to avoid harm. And then obviously it's also this iterative cycle of how DNA is extracted, sequenced, stored, and so forth. So once you've sequenced it, you shouldn't have to sequence it again, and it should be digitally stored. But one of the questions for the NHS will, where are you going to store it, and how are you going to access it to upgrade it? The other thing is clinical systems and interoperability, which I've alluded to before. So I remember one ward round I did, it took longer to log into the computer at the patient's bedside than it took for me to see the patient. And we shouldn't be in that situation. We're making clinical decisions about their treatment. So we need to make sure that our clinical systems are fit for purpose. And this is a real problem that came out really, really strongly, is alert fatigue. So those of you who are clinicians working in primary and secondary care, we ignore alerts a lot. And we need to be very, very clear that drugs that will cause irreversible harm are not ignored. And we need to find a way that we can change system behaviour, but also physician and healthcare worker behaviour to make sure that we don't end up in this situation. And something else that I've alluded to is this evolving evidence in drug-gene associations. And this will continue to evolve. I mean, we've already got the test directory, which is a really good starting point and highlights all the drug-gene associations we know about and which we can action. But actually, how do we keep on evolving this? And then education and training, which I think is really important. So I think genomics is often seen as something that is in the realm of secondary, tertiary, quaternary care, but we've all got a genome, we all take medicines, and actually I think that should be the starting point, and that should be how we all think about it. I've grown up in a system where actually, when I was a junior doctor, MRI wasn't very commonly used. I did stroke as a subspecialty, and I began to interpret MRIs myself. So it's not that we can't train our workforce to be able to do this, but we have to be able to have that training in place and actually across the entire health workforce that deals with patients, but particularly with patients and their medicines. So this is a really important part of how to implement it. And then the patient-specific factors. So I just listed some of the thoughts that actually our patient partners came up with and some of the concerns that they might have and how this might affect their ongoing healthcare. And the other thing that when you talk about genomics is patients often think, well, how is this going to affect my family? Because that's actually how genomics is sold to us. But actually maybe when it comes to pharmacogenomics, we can make the thought much simpler. This is how you take this medicine, and the rest might come after this. But if we make stop the process right there, then we won't move forward. So that's really important to be able to communicate to the patient. And then I'll just, these were the recommendations, and this is my last slide, in terms of the summary and the recommendations that we came up with and which we presented back to NHS England. So we thought from all the work that we'd done that actually a dual alerting strategy, both at the prescribing stage but also at the dispensing stage, might be the most useful to actually reduce errors, because then there are two healthcare professionals that are involved, both a doctor and a pharmacist, which is actually what's involved at the moment in terms of the medicine's life cycle. Actionable drug gene associations should be the ones that are alerted. That's what we should prioritise. That's what also sits behind the test directory, and that's what we should be focusing on. Implementation of pre-test and post-test pharmacogenomics alerts should be thought about, because there will be some instances where we won't have the data, so a pre-test alert is useful. Alerts should be very clear, they should be unambiguous, and they should be evidence-based, and they should recommend an action if they're going to be alerted at all. And they should be seen by healthcare professionals wherever in the life cycle of the medicine this is. And it should be implementation should be overseen by a multidisciplinary team. So anyone who's been involved in implementation on electronic health records, they fail, not because the system is bad, it's because the implementation hasn't happened properly. So implementation is key, but it's a multidisciplinary team that needs to oversee this. So I'll stop there, but I would like to say thank you to all of the people that were involved, which are listed here, that were on the paper, but there were many, many other partners that were involved in the discussions of this paper. And as I said, probably more questions for us to answer during the day, but thank you very much.
Thanks very much, Reecha. Questions for Reecha? Please.
Hi, my name is Jasmine. Thank you for the amazing presentation. It's really amazing. So I am a pharmacare prescriber. I'm also a community pharmacist. So a lot of the things you said really resonated with me. I guess my question is that, say we've got the pharmacogenomic test and we've got the answer, the recommendation, but what about if there's a price costing difference in terms of prescribing one drug against another? I guess in the confines of GP land, we are very much confined by CCG formularies and things like that. So how do we overcome that kind of issue? Because obviously we know clinically X drug would be the most important one for the patient. However, if we do a Y drug, which is cheaper, but also somehow helps because it helps a little bit, what would be the right one to prescribe?
Really good question, and I know Judith is in the audience, so I might just deflect to her in just a second before saying a couple of things. So I think this is really important, because I think, so some of the discussions we had during this programme were how does NICE deal with this? Because actually that's one of the things. How does it get incorporated into guidelines? Because if you've got a very harmful effect of one drug, but it is cheaper, of course a patient doesn't want to take that drug, and you don't want to give that drug. So how do we actually bring this into the policy arena? And actually that was one thing that we were very keen to follow up on. Judith, I don't know if you want to say anything, because obviously primary care is your realm.
to speak of
Not here yet. I think at the moment I don't really have very much to add to what you've said, Reecha. I mean, I think it's an evolving picture, and you know, you mentioned the evidence base there around actionability, and we know there's so many things that impact on prescribing decision, and some of the things that you mentioned, self-patient factors are another. So yeah, I think it's an evolving picture. We just need to keep asking like research questions, and as you say, just flagging it into policy as well, and ensuring that there is guidance, and it is incorporated into guidance as well. And I'm sure this will be mentioned as the day goes on, but I think interaction with Reecha and the ENM is going to be really crucial as well in development.
Can I also say that obviously this evidence base for pharmacogenomics also requires cost-effectiveness data.
Yes.
And if you look at cost-effectiveness data, you know, obviously what you substitute the drug with is part of the cost-effectiveness model. And so if it's a very expensive drug that you have to substitute with, then it becomes less cost-effective. But for the majority of cost-effectiveness models we've developed, the amount of money you save based on reduction in harm, etc., means that if it is even a slightly more expensive drug, it still remains cost-effective. So I think the cost-effectiveness model is really important part of it. Okay, one more question, and then
just quickly, you mentioned interoperability. I'm a cardiologist in Northern Ireland, actually, and we're slowly moving towards a complete EPIC system for the whole of Northern Ireland at the hospital level, but we're disjointed from the primary care colleagues who have vision and various different other platforms. So, have you got any solutions for the interoperability aspect of things? Or should it reside entirely with the patient?
So the patient is not a bad option. I mean, you know, if we think about what healthcare in the future is going to be like, you know, I always kind of think, is the tricorder possible? And for the Trekkies out there. So that's what, you know, we should aim for. And actually, we all carry mobile phones, so why shouldn't we all hold our own healthcare data? So I don't disagree with that. But I think interoperability will be a problem. And I think that's the next step in how we do make our healthcare records a bit more connected. And I think we are all going in slightly different directions. Secondary care is going this way with this provider, but those are what those standards are there for, and how we can communicate those standards across the piece. And I think that is an issue that really came up, is how we're going to make this genetic information available across the whole piece. So I don't have solutions, but I think hopefully they will come.
Great, thank you very much. And maybe we can pick up on the patient holding their own genomics data on the app and so on, because I think Northern Ireland has an app for the NHS in Northern Ireland, England has an app, and so on. Maybe that may be part of the solution, but we can maybe pick up on that in discussion later on.